renal pathology, acute tubular necrosis, also known as ATN. The first thing that we have to know about ATN is that it's the most common cause of acute kidney injury in hospitalized patients, okay? And thankfully for us, it's that it spontaneously resolves, okay? So in recovery, most patients experience tubular reepithelialization, okay? I know I just messed that up, but you essentially get more epithelial cells that are just made in place of the cells that died off, okay? That's all that occurs. Now, the key findings and most high yield thing that you have to understand, and they're always going to say it, which is surprising, but it's going to have granular, muddy, brown casts, okay? So granular casts, muddy, brown in appearance. That's like the key thing that you have to understand. You have to see what it looks like also on kind of histology, okay? And the reason behind this is because if you visualize it on histology, you see focal tubular epithelial necrosis. So essentially the epithelial cells are going to be necrosed. And there's 3 stages of ATN overall. Before we get to the causes of it, there's 3 stages. The first stage is inciting event, so something that causes the acute tubular necrosis, and we'll get to what causes it. Number 2 is the maintenance phase, which is going to present with decrease in the amount of urine output with an increase in potassium. So if you're not peeing enough, then you're going to have increased levels of potassium in your body. And then lastly, you get recovery phase, which is you're going to be peeing a lot, polyuric, okay? But you're going to have a complete decrease in your potassium inside the blood. So you get hypokalemia, and that's later on in the recovery phase. So you have to keep an eye out for both your potassium levels in the maintenance phase and the recovery phase, because when you're not peeing, you have an increased risk of hyperkalemia. And then when you are peeing during the recovery phase later on, you have a risk of hypokalemia, okay? Now, what are the 2 causes? What are the inciting events? The first event is ischemic, okay? For ischemic, it's usually due secondary to decrease in renal blood flow. And when we have decrease in renal blood flow, we have caused ischemia. And the areas that are affected, okay, are going to be the areas that have the least amount of oxygen supply. And where is that location? It's at the location of the corticomedullary junction, where the cortex and the medulla of the kidney meet. And the 2 locations there are the PCT, proximal convoluted tubule, as well as the thick ascending limb. And that's a question that they're going to ask you 1,000,000 times over. What is the most common site of ischemia in the kidney? You have to know the answer is going to be that thick ascending limb and PCT, okay? And the reason behind it is because it's at the outer medulla, okay? Most increased risk of ischemia, all right? And so that's why, once again, if we were to go to look back at intrinsic renal failure, that's why our urine osmolarity is low, our urine sodium is high, and the FeNA is going to be high, because we don't have the ability to reabsorb our water as well as our sodium, because we have necrosis, necrotic cells at the PCT and the thick ascending limb, where most of the sodium and water is going to be reabsorbed at the PCT, right? So that's the first inciting event, ischemia. The second thing that can cause inciting event is nephrotoxic, so something that can cause nephrotoxicity. This is going to be usually our drugs. And there's a bunch of drugs that can cause it. 1, aminoglycosides is a cause, okay? Lead agents, cisplatin is a drug. Ethylene glycol, right? Which is also, remember, affiliated with oxalate crystals in the urine. And also radio contrast. So patients that come in also in the hospital, they're going to be getting radio contrast or dye, okay, for maybe CT contrast scans, just in order to see maybe some vessels. Well, that dye can cause nephrotoxicity leading to acute tubular necrosis. So you've got to be aware of that. But nephrotoxicity only affects the PCT. Well, the reason behind that is because the drug, okay, the drug that's going to be entering the kidneys is just going to be first reabsorbed at the PCT, which is the first site of all the tubular system. And so since it's only at that first site that it's going to be reabsorbed, that's where the damage is going to occur, only at the PCT. Compared to the ischemic location, right, the ischemia is going to be present across all areas of the outer medulla, or where the cortex and medulla meet of the kidney. And that involves both the PCT and the thick ascending limb. However, for our nephrotoxic agents, it's only going to involve the PCT, not the thick ascending limb. All right? Now, one of the main causes that they want you to know for acute tubular necrosis is rhabdomyolysis. Okay, and rhabdomyolysis is not really covered well within the book as well as within your lectures. So rhabdomyolysis is something that you just got to know that they're going to be asking about. So what is it? Rhabdo is just skeletal muscle necrosis. So when you have skeletal muscle necrosis, usually in times of trauma, sepsis, drugs, overexcretion, or seizures, anytime that you have just like a crushing injury, something that causes skeletal muscle necrosis, right? Overexcretion, seizures, and crushing injuries are the most common. You get an increased release of intracellular breakdown products, right? So all the products that are within our skeletal muscle, they are lysed out into the environment and into our bloodstream. So then those go to the kidney to get cleaned out. So what happens? You're going to cause acute tubular necrosis, nephrotoxic acute tubular necrosis. And then the patient's going to present with myalgias, proximal muscle weakness, and dark urine. And this dark urine is myoglobinuria, which is just positive for blood on urine dipstick, but there's no red blood cells on microscopy. And that's due to the fact that there's myoglobin in the urine, because myoglobin is present within our skeletal muscle cells. All right? So I hope you understand that whole entire rhabdomyolysis and why that leads to acute tubular necrosis. I just want to keep that in mind. So overall, I hope you understand what ATN is. Make sure you know the key finding: granular cast, muddy brown in appearance, and you should be good to go.